Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I want to have a very important discussion with yet another special guest. Today I'm going to talk to Suzie Barry, my friend from residency, who is now a PICU attending. And as you know, Pediatric Emergency Medicine, I don't talk to the PICU very often, but when I do talk to a pediatric ICU attending, it's a very important conversation by definition. And so I figured it will probably be a very good idea to interview a pediatric ICU attending, and no better person I know than my old friend from residency. Welcome, Suzie, to the show. Let me just introduce you to the listeners. Suzie is originally from 29, and please correct me, Suzie, at any point if I'm wrong, please.
Okay.
Suzie is originally from 29 Palms, California. She went to med school far, far away from home at the University of New England College of Osteopathic Medicine in Maine, not too far from Boston, where I was living at the same time. And then she followed that with the residency in general pediatrics at Bay State Children's Hospital in Massachusetts with me. And I'm proud to say that Suzie was the second best resident in the program. I'm not going to say anymore. And I went to my Pediatric Emergency Medicine Fellowship in Pittsburgh, and she went to her PICU Fellowship at DuPont Children's Hospital in Wilmington, Delaware, and then moved to Albany, where she currently lives with her 4 kids. 2 of them she had at the same day, meaning they're twins in residency. And she is a pediatric intensivist and also the associate program director for the pediatric residency. And again, as I said, mother of 4. She's also married to a very cool guy and an excellent bass player who I had the pleasure of playing with when we were in residency. He taught me a few tricks on the bass, and he's a true musician, great guy. Welcome, Suzie. Welcome to the show. Good morning.
Good morning. Thank you for having me.
You're very welcome. Between your PICU schedule and your residency schedule, you're busy, I'm busy. I'm glad we made it happen. How are you?
Always busy. Great. How are you?
Very good. And again, thanks for your time. And let me start by saying, Suzie, my first question to you, and it's a question I ask almost all my guests. I always emphasize to the residents and to my students that as a pediatric emergency medicine physician, I really don't practice true emergencies most of the time. And by all means, I say that all the time. I consider myself humble enough to say it. Intensive care is a very, very small part of what I do. Most of the time, I treat kids who are totally fine, and the parents think they're very sick, but the kid is fine. And I see you guys, certainly PICU doctors, as the intensive care experts. You guys practice intensive care, I don't know if 100%, but by all means, majority of your time. And my question to you, Suzie, what is your ideal PEM physician to work with? The guy that calls you, or the woman who calls you for admission? What's your ideal PEM doctor to talk to?
Well, I really think of a PEM doctor as an extension of our team overall and caring for these really sick kids. But I really appreciate working with anyone who's a good communicator, above all, and really anyone that truly has the best interest of the child at heart. From a management standpoint, I would say it's nice to have a PEM doctor who's able to keep a broad overview while paying attention to the details. The details are extremely important in critical care. It's also helpful to just think a step ahead. An example of this would be if you have a child that you think needs BiPAP or sedation for a line, just don't let them eat, things of that nature. So I think that's important to keep in mind of what's the next step. I also appreciate someone who's kept the family updated, maybe even talked to us in the PICU a little bit and how great we are.
Very good. So yes, certainly good tips for us PEM physicians to know. And that's great feedback and information for us to know. You basically just quoted a few of my rules. I don't know if you've listened to them before, but rule number 39, a good ER doctor is always ready, be a step ahead. I usually think about it in a medical way, but certainly in a informing the parents kind of way and thinking ahead of maybe this patient will be intubated. Let's give him NPO. I got to say, I don't always think about that, but that's a great tip. And rule number 54, which I tell the residents and the medical students, which is set up your consultant for success. So our PICU colleagues are very good at what they do. I don't think of PICU as consultants really, but certainly I ask for their advice and I call them quite often. So when I admit a child who's going to need PICU, by all means, parents are probably very worried the child is sick enough. So saying something like, Mom and Dad, I know you're very worried, but let me tell you that your child is going to go to the PICU. Our PICU team are excellent. Your child is in great hands. So I try to build you up for success. I hope that works.
It's always a great point for trainees too. Just think of where the families are at, have some empathy about how stressed they are in that moment. And as much as I deal with it on a day-to-day basis, critical illness, if it's my own kids, it's completely different and everything flies out of my head. It's an extremely difficult time for people.
Sure. What else can you tell us about having a maybe better communication with regards to working with the emergency department?
So like I said, it's really an extension of PICU. So it's good. The communication piece is so important, even outside of the clinical realm. So because we work so closely with the PEM docs, in our situation, for example, we've been having a monthly PICU and PEM conference to discuss cases. This is something that was brought to us by one of our PEM docs that started in the last couple of years. And I think it's an excellent opportunity to see how we can improve systems issues or simply educate each other on our points of view and just medical management and give each other tips. It was started by, like I said, one of our PEM docs. So it's just been a great way to work more collaboratively and simply get to know each other better.
Yeah, so that's actually a really, really good idea. Not something we do in our hospital, I must say. But yeah, I think we don't speak to the PICU very often. And when we do, it's by definition a critical or somewhat critical patient. So I think having better communication and those kind of meetings actually sound really good. You may have hopefully just inspired some of our listeners to do the same. And in your experience, Suzie, what is the most common reason a PEM physician calls you? And what message would you give them? What should they change? What can we do better? I mean, obviously, we call you for admission, but within that realm of admission, what do we call you about the most? And what tips would you give us to do a better job?
So exactly like you said, that I'm usually just getting called to admit somebody that the ED is triaged and felt needs closer monitoring or higher level of intervention. And I'm trusting my PEM colleagues to appropriately triage these patients. So if they say they need me, in my situation, usually I just take that as it is, that they need me. My biggest piece of advice is to reassess the patient before calling me. I definitely know that things get busy and sometimes there's a lapse between times of assessment and when you get a chance to sit down and call. But I've definitely been blindsided by discrepancies between a picture that was painted to me and what shows up on the unit due to just these long lapses in reassessment of a really sick kid. I'm also often called for advice. And to be honest, I really appreciate the humility in that effort and truly don't mind talking through the case, even if it just provides reassurance in the end, because that to me is a sign that the doc taking care of those kids are really just trying to gather whatever information they can to take the best care of them, and being humble and that we don't always have the answers and reaching out for help.
Very good. When would you say, and I guess, and I think that's also a very, very good tip. Again, not something that I always remember to do, got to be honest. Sometimes we're very busy and just kind of time flies by, but certainly assessing or reassessing the patient before you talk to the consultants, because often they ask, what does the kid look like now, is a very helpful tip. When is the best time, or when should an ED physician consult you? Under what circumstances do you feel like you should get consulted?
So I think an ED doc should call me whenever they have a kid they think is sick enough to need closer monitoring. Kind of as I mentioned, I'm trusting the PEM docs to be able to triage that, and they do a great job to do it. But there may be times when I get the story, talk through it, and suggest the kid goes to the floor rather than a PICU, which is definitely not to deflect work, but rather to ensure we are preserving the resources of the PICU as best we can. And this is an important point I always like to emphasize to PEM colleagues, and especially when census is high. And I know a lot of people were in a crunch for high census, poor staffing, especially during the pandemic. So I think it's something to be aware of, that the idea of guarding this last PICU bed is very important. And I always say, think of it like this, as an example, say you admit a moderate DK kid to the last PICU bed, and then later you get a child after cardiac arrest, and the kid's intubated, they're on high vasoactive support. And now there's a delay of this much sicker kid sitting in your PZD until the PICU can triage a less sick kid out of the PICU and turn over the bed. So the care of that second patient will be much more time consuming and disruptive to a busy PZD than a moderate DK child would be. So it's always worth a conversation when resources are scarce, and maybe worth a watch and wait approach sometimes. So I always say my most valuable resource in the PICU is that last bed, and definitely a free charge nurse when I can get it. On the other hand, I definitely have had people apologize to me for sending someone who didn't end up needing anything significant. But in the end, the way I see it is if the outcome was good, they did the right thing.
Very good. So that's actually a very, very good advice that I don't think us PEM physician necessarily think about. You may have just given me a new idea for a new rule: preserve the last PICU bed. That's great. And yeah, I mean, I work in the ER. I think of my patients as, what they need now. And once I kind of maxed out and I speak to you, I try to get the kid upstairs as soon as I can. But certainly thinking about your situation and that last PICU bed, like you said, is a very, very good thing to be aware of. So I think that's great for my listeners to hear about. And if you listen to my podcast, Suzie, it's all about rules, which are really not rules. They're more like clinical tips or advice. What are some PEM rules or PICU rules that you live by?
So my number one PEM rule, PICU/PICU rule that I give to especially our trainees from the ED that come through the PICU is to always use a cuffed ET tube. So it sounds like a simple thing, but it's so important. The reason is because tracheal intubation is arguably the most dangerous procedure we perform. So typically when it's being done in the context of critical illness, it's for respiratory failure because of a patient with an inability to regulate their ventilation due to neurologic insult. And in both situations, a cuffed ET tube allows us to more reliably control our ventilation. So if we have a patient present with an uncuffed ET tube, chances are we'll eventually have to swap that out for another tube, a cuff tube. And that's a risky procedure, arguably more risky now that we have a child who's had the airway manipulated multiple times and they're decompensated just in the setting of critical illness. So very important. Always use a cuffed ET tube.
Very good. Again, very good advice coming from the experts. I think I think somewhere in residency, one of our attendings told me that uncuffed tubes don't belong anywhere except for the NICU, something like that. I think in the NICU, we did use uncuffed tubes, but that's pretty much it. I agree with that advice. I think that's a good advice. Certainly, if it makes your life easier later on or the patient's life easier later on, by all means. Yeah, so that's a very good tip.
Yeah, everything I learned from an attending in fellowship to always think about things as risk benefit and just think of that ratio. And in any situation, you want that to be more of a benefit, of course. So just think of it in that way. And also, if there's no benefit to a certain intervention, then your risk is infinite.
Very good.
Yeah. So can I ask you a question?
You can ask me whatever you want. Absolutely.
All right. So I want to know if you think it's helpful when the ICU attending is able to come to the bedside for a sick or complex patient to help with co-management. And this is something that's come up in busy times in our unit. We're not always available to leave our unit if there's a really sick kid, but when we are, and to look at how we have our unit set up and our collaboration with the ED, is that something you find helpful? If we had things set up with a PICU doc that was maybe free at certain points in the day to come down?
Yeah, so that's a great question. And by all means, my personal answer is definitely yes. And for several reasons. First, like I said, and again, I tell that to my residents and my med students who thinking about pediatric emergency medicine. I have to be honest. I am a pediatric emergency medicine physician, but intensive care or even true emergencies is about, if I had to quantify, 10% of what I do. And I see you guys as the experts in intensive care. So it's no different than calling the nephrologist when I need help or a question or I have a question. I have to know what I don't know. So I think it helps me to have you guys or PICU attending come to the pediatric emergency department. So by all means, as far as I'm concerned, it's a yes. Now, in addition to that, in a single coverage unit, like where I work here in Orlando, just having another attending, another set of hands is always a blessing when I'm, managing a critical patient. Sometimes, not very often, a critical patient comes in when the resident is not there or before the PA comes in peak hours. So it's especially helpful to have another set of hands, again, especially if it's an expert. Lastly, as you know, we are all in the business of education, those of us who work in academic centers and those of us who are not even. And if I have a resident, I think it's an extremely valuable educational experience for him or her to watch a PEM and a PICU doctor in action, working side by side for the benefit of the patient, leading by example. I think they can really, truly learn from that experience.
Yeah, I agree. It's something I like to do when I can. I agree. It can be difficult depending on your practice. We're in a single coverage unit as well. And so I'm not always available to leave the unit, but if I can, or if someone explicitly tells me they really need a hand, I always try to accommodate that. And I agree too. Like when you're by yourself, it's a different experience. I think of in training when there's always other people around. It's just a bit of a comfort, and to run things by somebody else is always nice. And definitely 100% as far as leading by example for our trainees. So I urge everyone to always act and interact as if a learner is watching, because chances are they are. And dealing with sick kids is tough. It's really tough. So I think we should all work collaboratively, give each other honest feedback, support each other, and especially give each other some grace when we're fatigued. So when it comes to having a sick child present, even if it's not, but especially when the outcome is bad, please check in with yourself, your colleagues, your residents, and your staff. And we may project handling things well, but you never know who feels like they're the only one struggling. So I try to be transparent and make sure we're all supporting each other. And that definitely includes our PEM colleagues.
Excellent. Again, those are really some good tips for us PEM attendings to know, certainly to have a different perspective from the consultants or the colleagues that we may not call or talk to very often, but certainly when I talk to a PICU doctor from a clinical standpoint, it's a true emergency. So thank you, Suzie, very, very much for your time. And I think you mentioned to me you like the Police.
Absolutely.
What's your favorite Police song?
Oh gosh, you had to ask me that. I don't know.
How about,
there's one I don't know the name of it, but
how about Every Breath You Take?
That one's a little creepy.
What? The lyrics?
Yeah.
Yeah, well,
if you listen, it's like a stalker.
Yeah, I heard that theory before. Having said that, it's a great song.
It is a great song.
Great guitar line, which I've been working on for months because I have no talent. So yeah, try that one.
All right.
Well,
I think Every Breath You Take is a good one because it's fitting in the setting of what I do as an intensivist.
Perfect.
Which, when you really think about it, in the end, is establishing oxygen delivery. I say that's the core of ICU medicine. And so Every Breath You Take actually in this situation is extremely fitting.
All right, perfect. So here is Every Breath You Take by the Police, or by me trying to be the Police. Hope you like it. Thank you, Suzie, for your time. Thank you very, very much.
No problem. It's my pleasure.
Bye-bye.